Hello and welcome to yet another episode of Dr. Sin. Today we have with us Dr. Arun George, who have been specialized in oral and maxillofacial surgery. Let us welcome him to the program. Welcome, doctor.
Thank you.
Could you tell us your experience in the field of oral and maxillofacial surgery?
I've been practicing oral and maxillofacial surgery since 2005. I've completed my post-graduation and I've joined Marbe Dental College and Hospital. And I'm currently working as an associate professor there. So we have been doing all kind of maxillofacial surgical procedures for the last 6 to 8 years there.
Okay.
So this is my basic experience, and we are working. Our center is probably known for facial deformity corrections. We are also into trauma and some kind of pathologies, but we are more towards facial cosmetic surgeries and orthodontic surgeries. Previously, there was no specialities in dentistry. There was only the degree was called only Bachelor of Dental Surgery. There was no post-graduation. So later years, it developed as we have somewhere around 6 major clinical branches. Like oral and maxillary surgery is definitely one of the branch.
Okay.
Then pediatric dentistry. Then periodontics, that is related with the gum diseases. Then conservative dentistry and endodontics. Then we have prosthodontics. And we have orthodontic. These are the major clinical branches. And we have oral medicine and radiology, oral pathology.
What are the various branches in the dentistry?
So there are 9 various branches in dentistry, like orthodontics, prosthodontics, periodontics, pedodontics, prosthodontics, and pediatric dentistry. These are the major clinical branches. So I am basically a consultant oral and maxillofacial surgeon.
Now, could you tell us what is actually oral and maxillofacial surgery?
Oral and maxillofacial surgery as such is a speciality of dentistry. It is basically related with treatment of diseases related to the oral cavity and the maxillofacial region. So it includes various oral minor surgical procedures and major surgical procedures.
Okay.
So minor surgery is all about any procedure which can be comfortably carried out by a dental surgeon in not more than 30 minutes under local anesthesia. So those surgeries includes removal of a wisdom tooth. It's a complicated tooth extraction, or root stumps inside the jaw. Or sometimes when there is you need to manage an infection. It is called incision and drainage.
Okay.
Or it's a pre-prosthetic surgery, pre-orthodontic surgery, surgical exposure of crowns, frenectomy. I mean, we have a series of minor oral surgical procedures. It is basically a procedure inside or the oral cavity to correct various ailments. In the same speciality, the other end is maxillofacial surgery. So it is definitely a major surgical procedure, usually carried out under general anesthesia in a major hospital or theatre setup. So the maxillofacial surgery, we have various sets of treatments in maxillofacial surgery. It includes trauma. Trauma is all about we are treating accidents, major. It can be anything: major accidents, interpersonal violence, fall. So any kind of accidents. So it can be even sometimes these accidents or this trauma patient comes with a head injury. That means you need to have a support from the neurosurgeon or allied specialities. Okay, and the other set of treatments usually are related to pathology. We treat cyst, tumors. It could be a benign condition, or it could be an aggressive malignant condition. So we have a series of cysts and tumors or the pathological conditions. So that is another area. Then we are into other area is cancer surgeries of the head and neck region. So which sometimes need an aggressive treatment. So the other area is the treatment of oral cancer, which involves first diagnosis. That is we take a biopsy. We have an incisional biopsy, excisional biopsy. So we diagnose a situation, and we need to take the patient sometimes for a resection of a particular region. inside the oral cavity or a maxillofacial region. And we have a set of pre-malignant lesions and conditions like, oral lichen planus, then oral submucous fibrosis, etc. And other area in oral and maxillofacial surgery, which usually an oral surgeon does, is cleft and craniofacial disorders.
What is that?
Cleft surgery is all about, cleft is a condition, usually it is an inherited, hereditary or a congenital anomaly where a patient comes to you with a defect in the lip or a palate. Sometimes it could be a defect only on the lip, or sometimes it could be a defect in the lip which extends to the soft palate, to the hard palate till the uvula. Sometimes the patient can it includes a rare facial cleft. So we have a set of classification for that. So this is again another area of oral and maxillofacial. Previously these procedures were only practiced by general surgeons, plastic surgeons, and this is actually a cleft is something like a group of people does this, treat this situation, like ENT surgeons, plastic surgeons, pediatric dentist, orthodontist, maxillofacial surgeon. It is all about a teamwork. It's not only by a maxillofacial surgeon. It's about when speech therapist is also required. So because the cleft patient usually have multiple problems, starting from the feeding problems, ear infection, speech, their feeding, everything is affected. Okay. And another area of oral and maxillofacial surgery deals with corrections of the facial deformities. So that area, our center is more focused on the treatment of facial deformities and this allied deformities of the face. Okay. And these procedures comes under, or it is a super specialty of oral and we can call it a super specialty of oral and max. It needs again a training. Oral surgeons needs to get trained in orthognathic surgical procedures.
What is orthognathic surgery?
The orthognathic surgery, actually the word meaning of ortho is straight and gnathia means jaw. So we have upper jaw and lower jaw. Upper jaw is called maxilla and the lower jaw is called mandible. So orthognathic surgery is all about straightening of the jaw. That is the exact word meaning. So normally the patient with facial deformities, because when we are talking about facial deformities, it is not just about problems associated with skin.
Okay.
So when we talk about a cosmetic facial surgery, it is all about removal of a pimple or tightening of the soft tissue, facelift and all. There are so many plastic surgical procedures. Orthognathic surgery is all about restructuring the facial skeleton. That means you are going to cut or restructure the bone.
Okay.
Okay. So the deformities usually associated with orthognathic surgeries, or probably the deformities we treat, are the problems associated with the maxilla, that is upper jaw, or the lower jaw. And first we need to diagnose a situation or the problems associated. So our problems are basically you can anticipate, a patient, comes for an orthognathic surgery. He can be with the maxilla. Maxilla can be prognathic, that means excess. Excess of maxilla in vertical plane, horizontal plane, that is anteroposterior excess, transverse. And the same way, it can be deficient also. Vertically deficient, horizontally deficient, anteroposteriorly deficient. So these are the three situations we can anticipate in maxilla. Same in mandible also, it can be excess because we call it as a mandibular prognathism. Because a normal person, when the teeth gets aligned, lower teeth always comes behind the upper teeth.
Okay.
For a skeletal prognathic mandible, lower teeth always set far away from the upper teeth. prognathosum, anteroposterior. And there can be vertically also excess. Because there is a normal division for the face. And the other issues are there is something called hemifacial microsomia. There is a situation where one half of the face is affected because one half of the face has got a normal growth and one half of the face has got a retarded growth. So naturally what happens is that face deviates to the affected side. This from this side, if you think that the left side is normal, so the chin deviates to this side. The one side, this is a malar bone or a zygomatic bone. This becomes flat. This side becomes, that length will be short. This is the ramus, height of the, the mandible. The vertical height as well as the horizontal height becomes shortened. Sometimes, that ear cartilage and the structure of the ear becomes small. And even it can affect the frontal bone, that is the cranial bones also sometimes gets affected. So that is about hemifacial microsomia. That is a kind of deformity. And there are some deformities, it comes under facial asymmetry. Asymmetry means nobody's face is exactly symmetrical. That is a concept. Because if you exactly divide a person's face on left side and right side, if you look very keen or when you are to the deeper side, if you will find that there is some amount of asymmetry, but it is acceptable for a normal person. But for a person with a facial asymmetry, that means again he has a problem on one side, or there is a deviation, or the nose, one side of the nose is affected, other side can be normal, or it can be vice versa. So that is about the facial asymmetry. I've told you about cleft, but our center we don't do a primary cleft surgical procedure. We have actually a set of centers where they operate cleft lip and palate for free. That comes usually under smile train. There is an association which treat primary cleft free of cost. We don't do that. We don't have that setup. And I also wanted to talk about another deformity that is called temporomandibular joint ankylosis. That is again a congenital kind of deformity, or probably just you will find that deformity immediately after the birth. That is fusion of the upper and the lower joint space. This is a temporomandibular joint. And it is basically because of the childhood trauma. If it affects a temporomandibular joint ankylosis at birth, or probably it is called a forceps delivery, the growth of the mandible gets completely affected. So the vertical height and the horizontal growth, and because the condyle is the head of this joint space, it gets affected and the growth gets affected and it gets deformed. And most of the patients, this patient will have difficulty in mouth opening. If it is a true bilateral temporomandibular joint ankylosis, patient will have very minimal mouth opening. The patient will not be able to open the mouth. Okay. So that is one thing. The other thing is that they take a bad face deformity. That is called an anti-gum deformity or a bad face deformity. The chin, they will lack completely the chin. They will not have a prominence for the chin. The chin neck angle will be completely distorted. So they will have a lot of problems with their face. A lot of disfigurement. They will have a convex face. So that is another kind of deformity. I think these are different various kinds of deformity. And the next issue is how to diagnose a deformity. So the first and the foremost diagnosis is always comes from a clinical diagnosis. You look at a patient, if you are an experienced person, if you look at a face, you can diagnose almost because it is not a final diagnosis, but because you have a set of chin prominence, the prominence of the nose, prominence of the lip, and the lip competence, that is whether the patient is able to close the lip properly, prognathism of the mandible, almost all this clinically you can diagnose by just looking at a person, and we call it as an inspectory finding and a palpatory finding. You just inspection, you're just seeing a patient. Then we have a set of radiographs that is called a lateral cephalograms. We have a frontal cephalogram, and we can also take a three-dimensional CT scan. That is, you take an axial and coronal cuts, bring into a computer software that gives you a three-dimensional image of the facial skeleton. So when you have a complex kind of deformities, this same three-dimensional CT, if you transfer, you can make a exact model that is called a stereolithographic model. That is a replica of the facial skeleton you can make. Okay. If you have a patient, you can make the model of that patient by taking a CD and transferring the CD to a lab which has the facility of making a stereolithographic model. We have a set of, again, a lot of diagnostic tools. Again, the photographs, then these models, X-rays evaluation. Then there is something called cephalometrics. Cephalometrics is all about, have a set of normal landmarks on the facial skeleton, which we take certain points in the facial skeleton and you draw lines and, you have a lot of measurements. Then you can do a model surgery. You take a model of the patient and you do a surgery on model. That is called a mock surgery. And you can, assume how much you need to move a segment of bone to reach a near normal stage. Okay. Then you can perform all these procedures in software. That is we can do a mock surgery, or there is something called prediction softwares, because you put all these findings in a software. The software will tell you how much excess of the bone you have, how much you need to take it back, or how much you take it up. So because all your problems are associated with either excess of the bone or a deficiency of the bone. Either it is unilateral or it is bilateral. So these are the basic problem is all about the difference, because what we are treating is the problems of the bone. The model surgeries. So all these are the various tools for diagnosing a problem. Okay, so once you have diagnosed the situation, the next issue is how to go about with the procedure. And most of the times, when you are treating a patient for orthodontic surgery, when you are mobilizing the jaw, because you are mobilizing an upper jaw or a lower jaw, you are, troubling, or you are creating a problem for the occlusion. There will be an occlusion, means there will be a difference in the bite. When you are moving a segment, there will be, because when you are cutting the bone, you are moving in terms of millimeters or centimeters, because you are taking a centimeter up or centimeter, sliding anteriorly or posteriorly. But the fine occlusion is all about you need to move tooth in millimeters to get the final occlusion. Okay. So the treatment usually starts with a pre-surgical orthodontics, because you need to align the tooth. Because most of these patients who comes for orthodontic surgery, they will have problems associated with their tooth, because there will be a spacing between the tooth, or there will be crowding, or whatever be the reason. You have a set of pre-surgical orthodontics, that is orthodontics prior to surgery. Okay. So once that is the first phase, once you are diagnosed, then planning for a surgery, because you have to assess the patient as a whole. You have to take a good history, case history, health status. So once the patient is fit for surgery, that means you have to get an anesthetic clearance. That means the patient has to be, healthy to undergo a surgical procedure. So you diagnose, do a thorough evaluation, plan for the procedure, and this is a procedure usually takes around 2 to 3 hours. Means normal orthodontic surgical procedure can take 1.5 to 2.5 or 3 hours. So you can anticipate it's on an average 2-hour procedure if you are doing a single jaw. Sometimes you do a surgery on one jaw, or sometimes along with maybe 2 jaw surgeries. So it depends. Patient needs a hospital admission one day. Usually that is how we follow. Hospital admission one day prior. The next day morning, usually we take the patient for surgery. It depends on the anesthetic convenience and the hospital convenience, everything. Sometimes we need to arrange blood. Blood may be required for this procedure. Blood transfusion may be needed, depends on the blood loss. and we do the procedure, and it is called osteotomy. The surgical procedure is called osteotomy. Osteotomy means splitting the bone. So we are intentionally fracturing a bony segment. Okay, so it is all about, if the maxilla is excess, we cut some amount of the maxilla 3 to 5 millimeter away from the tip of the root.
Oh.
Okay, because it should not damage the blood supply to the root. There are some principles, strict principles we have to follow. We should not compromise the blood supply to a particular region, because that segment will go in for necrosis. So we have a definite protocols and principles we have to follow for this orthodontic surgery. So we need to, it is called osteotomy. So we do an osteotomy, and we have already, because we have diagnosed situation, we know how much amount of bone needs to be mobilized, how much amount of bone needs to be trimmed from each segment. So we do accordingly, follow all the principles, and osteotomy is done, and we are just refixing the segment. Okay, if it is the maxilla, sometimes we take the maxilla up, that is superior repositioning. Sometimes you take it posteriorly. Sometimes when you want to take the anterior segment, you extract premolars, that is one tooth distal to the canine, usually that is. So that procedure is called anterior maxillary osteotomy, so that you can take one segment, anterior segment posteriorly. And if you want, you can advance the maxilla. So again, depends on, if the maxilla is deficient, you can advance it. And same way with mandible, with the procedure, the commonest procedure for the mandibular, again the osteotomy is a common name, bilateral sagittal split osteotomy, that is for cutting the mandible, splitting the mandible sagittally. Then there is something called lower subapical osteotomy, where you extract a lower premolars and moving the segment posteriorly, that is in the anterior region. Then for correcting the chin, sometimes this is the commonest problem with our population. One of the problems is that some of the people may be deficient with the prominence of the chin. Sometimes the chin may be deviated to one side or any side. It can be deviated, or it can be deficient, or even it can be excess. So the procedure for correcting the chin is called genioplasty. So we have an advancement genioplasty, that is a sliding advancement, or you can cut the genium and you can align the midline. Or sometimes if you think the genium is more, you can remove some amount of bone and you can take it back. Some of, or probably most of the patients with ankylosis, they have very minimal amount of chin. So such patient, we need to cut the genium from one side to other side. That is called extended lateral sliding genioplasty, where from the one side of the ramus, that is from here to here, we split the mandible. You take the entire segment anteriorly, and you can flip or you can rotate to any side to advance the genium when the deficiency is more. Okay, or when there is shift towards one side, you can just simply cut and you can advance it and you can correct it in the midline.
So the patient should be very careful once the operation is done.
Yeah, so normally, these are all various procedures, and I also wanted to emphasize one more procedure, that is called distraction osteogenesis. When the discrepancy is more, if it is more than 10 millimeter or 14 to 15 millimeter deficient, you can cut a segment, you can put some distractors. That is, a distraction is it is all about lengthening the bone, because previously this procedure was only advocated in the long bones when you wanted to increase the height of a person, because it was this principle, this procedure was first propagated and popularized by Elizaro. And in the year 1992, McCarthy was the first person to introduce this the distraction to the facial skeleton. Okay, so when you have a deficient maxilla or when you have a deficient mandible, what you do is, we have a distractor. It's a small device with screw, and so once you fix the distractor and you split the bone, you turn the screw. Okay, you can advance any bone segment 1 millimeter a day. That is a principle, because if you cut the bone, if you divide the bone and you advance 1 millimeter a day, bone, a bone fills the gap. You cannot just simply advance 10 millimeter or not. But and the very next day you advance 1 more millimeter. Third day again 1 millimeter. Like that, 10, 15 days you can, 15 days you can advance 15 millimeter. So that in between the bone, new bone forms. So that is about distraction osteogenesis. That is also incorporated. That is the latest happening in the field of facial deformity correction, because most of these cleft patients with a lot of maxillary deficiency, you cannot simply advance a maxilla by orthodontic surgery. So the protocols of distraction is followed for advancing such cases, for a, when the deficiency is more. And you are asking about the hospital and how the postoperative care. Naturally, the patient is admitted immediately because you can expect a lot of swelling. Yes. So we need to give some steroids. Usually we follow 2 to 3 days. We give dexamethasone. That is the commonest kind of drug we give for such patients. Steroids to reduce postoperative edema and swelling. And naturally, the patient has to maintain a very good oral hygiene. Okay. And usually we keep the patients 4 to 5 days prior to the surgery in our hospital setup. So we give IV antibiotics, IM injections for pain, then drugs for controlling the pain, drugs for preventing secondary infections. So all these things are it is all common for any major surgical procedure. So those things are continued for another 4 to 5 days, and usually we discharge after if it is the procedure is uneventful, we discharge the patient after 4 or 5 days. And the postoperative phase, we advise the patient to take a good rest for 2 to 3 weeks, because the patient will have swelling, and naturally the patient would have had a very big change for his facial skeleton, because he needs to accept the new face. And our experience, most of the patients after orthodontic surgery, they become very confident, their profile improves. Because we are when the discrepancy, when the deformity is more, because when you are treating an obvious deformity, it improves, or it really elates the mood of the patient, because they become socially more active. Yes. They become more, they act more in their works, everything, that they become more socially acceptable. So it works in different ways. It improves the functions, because when you have a deformity, your mastication, your chewing habit, your, a lot of issues related to the functions are there. Then naturally aesthetics, the appearance of the patient, because they are mentally, kind of, troubled. They are patients who are not happy in life, usually deformed patients. And you are correcting a function, you are correcting aesthetics, and you are improving their psychosocial problems, because they are you are really helping them to achieve a bigger or a higher state of mind. So that is what exactly happens. Okay. So we follow up this patient and the postoperative follow-up immediately after the surgery, or probably after 1 week, we have to start again with the post-surgical orthodontics, because most of the patients, when you mobilize the jaws, they will have problems with the occlusion. So you start up with settling elastics, correcting the occlusion. It takes 6 months to 1 year. So the whole treatment takes 1 to 1.5 years, including orthodontics. And cost of the treatment, probably because it ranges from, I tell you, 50,000 to 2 to 3 lakhs. Oh. Okay, it depends. Okay. Because we have our when we operate, it depends on where you operate, the hospital charges, the kind of hospital. Yes. Our procedure is going to be same. So most of these patients, immediately after the procedure, we have to take the patient for again postoperative care. the patient post-operative immediately after 1 month of this post-operative care is little difficult because the patient complains of little bit of swelling,
Yeah.
pain. So you need to somehow tackle or probably to manage
Yes.
that situation. That is needed for probably 1 to 2 months. So normally the swelling subsides within 3 months. So what our whole treatment is all about is, it is like you are treating a fracture, because you are fracturing a bone
Yes.
and you are refixing it. And normally it takes 3 to 6 months time to heal the bone. And when you restructure the bone, the soft tissue follows. Because you know that you are taking, when there is a excess of the mandible, you take the mandible posteriorly, soft tissue also goes posteriorly. So you get an acceptable face. So that is why this orthodontic surgery works. So I just wanted to finish so this is a you need almost nearly an year follow-up, and most of the times our experience, the patients are really happy after this procedure. Of course, like any surgical procedure, it can also have some amount of complications. Sometimes the tooth can go non-vital. Sometimes there can be an infection, periodontal problems, infections. Especially when you are doing a mandible procedure, there can be numbness because it can damage a sensory nerve. The numbness, sometimes it lasts for 3 to 6 months or sometimes maximum of 9 months. But usually, in our experience, even if there is a numbness, the nerve regenerates. And these problems are all temporary, and there will be problems of occlusion which we can correct with elastics, settling elastics. So these are the perioperative care regarding orthodontic surgery.
Doctor, thanks a lot for spending your valuable time with us. So that was Dr. Arun George with us. Until we meet next time, this is me, Naina, signing off. Take care.